Good morning. I hope I'm audible to all of you. Uh, Thank you for that introduction, Dr. Uma Saikya, and thanks to the organizers for inviting me to give this talk. Krishna, thank you for that explicit presentation. So I'll be talking to you about the aspect of fibrocalcic pancreatic diabetes. But since we have an August panel who will be discussing many aspects with their questions which are being asked of them, I will deal with a few aspects and I will not touch on some of the other aspects which may be overlapping with the basics of fibrocalcic pancreatic diabetes. So I'll be focusing on some of the clinical features and the background of the disorder, the variability in pancreatic size, other genetic conditions which mimic fibrocalcic pancreatic diabetes mellitus, some advances into hormone physiology, and finally, the therapy. So it's all started perhaps more than 70 years ago, and without alluding to this slide, I should mention that the first postmortem study which diagnosed fibrocalcic pancreatic diabetes was at Velo in the year 1954. And of course, subsequently, the first cases were reported from Indonesia. And of course, you can see quite clearly that the distribution of the disorder is essentially absolutely tropical between the tropics of Cancer and Capricorn, but for a few areas in South Africa and perhaps in Argentina. If you look at the clinical features, and as the case had mentioned, it is classically described as abdominal pain in the first decade, which is often underrecognized and may in children very often be wrongly attributed towards worms or a psychogenic abdominal pain, maldigestion leading to steatord, which can be detected ideally with a 72-hour stool fat, which is a test which is moving out of vogue now and using elastase levels in stool to be measured, and preceded by a phenomena called tropical pancreatitis, wherein the individuals are invariably lean and have a low BMI, generally less than 20 kilograms per meter squared. The diabetes, when it develops, is called fibrocalcic pancreatic diabetes with low to moderate insulin requirements, and there's a 40% risk of pancreatic carcinoma from the fourth decade onwards, provided they do not succumb to the onslaught of the usual microvascular, macrovascular complications added to the malnutrition that they face with the malabsorption that they have. So critical for diagnosis, besides the fat malabsorption, is ruling out other conditions wherein you have insulinopenic diabetes, the C-peptide levels are low, and an ultrasound or a CT abdomen beyond that with plain X-ray of the abdomen is useful to show the classical duct dilatation with chunky calcification and intraductal stones. So what I would like to herald over here is that a number of patients who come are underdiagnosed because people do believe that the prevalence is declining, particularly in some of the southern states, but it's still very much there. This is from our own database with lean diabetes mellitus, 20 kgs per meter squared. When they were referred to us for treatment, they had not been screened previously. And without a pancreatic imaging and a GAD antibody, we found a number of patients, in fact, who had fibrocalcic pancreatic diabetes, only second to underdiagnosed type 1 diabetes mellitus. Now, the important aspect is to differentiate it from the more common form of pancreatitis and the alcoholic chronic pancreatitis. And this list was published about 2 decades back by the group from Chennai. And the alcoholic pancreatitis, of course, in Indians is largely in males, has a later onset from fibrocalcic pancreatic diabetes, and is generally more well distributed across social strata. The course of diabetes is much slower in alcoholic disease. Diabetes occurs, of course, almost invariably in the fibrocalcic pancreatic diabetes group. And pancreatic calculi are large and are usually very dense without the speckling that alcoholic pancreatitis has. The duct dilatation is generally marked. There's fibrosis of the gland, which tends to shrink the pancreas much more. And there is, of course, a potential for overlap between alcoholism and this form of pancreatitis in addition. And of course, the prevalence of malignancy is extraordinarily high. So if you look at the mutations which are associated with primary exocrine dysfunction, These are the ones which I would like to highlight. The SPINK1 mutation, serine protease inhibitor Casal type 1A, the PRSS1, which has an impact on the cationic trypsinogen, therefore inducing an octoactivation of digestion within the pancreas. And of course, the cystic fibrosis transmembrane conductant regulator, which is definitely there in India, but perhaps a little less common than the other two. So what happens by and large is an autodigestion phenomena which occurs, and you can see over here that the activation, as you can see over here, trypsin effect is lost, and with the mutation of SPINK, there's an increased production of trypsin, enzyme cascade, and subsequent autodigestion with pancreatitis. Now, this is our work on fibrocalcic pancreatic diabetes, looking at those who had fibrocalcic pancreatic diabetes were SPINK positive versus SPINK negative. And we find over here that many of the variables are similar. Having said that, there are differences. The stool fat excretion rates were higher. This is a 72-hour stool fat in those who had SPINK mutations. Insulin secretory rates were also worse. And glucagon secretion was more or less the same. Having said that, statistical significance-wise, it was less in the SPINK1 mutations compared to the ones who were SPINK negative. And more interesting is that the insulin resistance at the level of the periphery was higher in those who were SPINK negative. So basically, we have subsequent dysfunction in the SPINK positive patients, poorer insulin secretion, and greater peripheral resistance. Now let's focus on another aspect, the aspect of pancreatic size. And I'm not talking about fibrocalcic pancreatic diabetes here, but there is definitely a shift towards a change in pancreatic size, even with other disorders, much simpler than that of fibrocalcic pancreatic diabetes. So there is a minimal reduction in pancreatic size with type 1 and type 2 diabetes. And if you have an oversensitive radiologist, this may be actually picked up, though is not that clinically discernible. With insulin usage and the presence of pancreatic insufficiency, the pancreatic size is negatively correlated. But it is positively related to body size, both on imaging and autopsy studies. If you look at this particular table, which was published in an article in Nature Genetics about 10 years back, it tells you quite clearly here in terms of the correlations with pancreatic size. And of course, there's a more profound decline in pancreatic size with a long duration of type 1, a little less with type 2 diabetes as they become elderly. Fat content on an MRI SPECT is increased with increasing body weight and an increase in type 2 diabetes. But in type 1 diabetes, there is no change. Calcification is not a feature, and the ultrasound reflectivity is increased with age and with body weight. So these are important things to know in the background to prevent false positives or false negatives in this situation. And I shall allude to the correlation with pancreatic diseases on the rest of this table as the talk goes on. So there are other genetic conditions which mimic fibrocalcic pancreatic diabetes mellitus. And these include several mutations which form the monogenic disorders which can cause diabetes. I've listed them over here, but I would particularly like to talk about the HNF1 beta and the CEL mutations. These can actually lead to pancreatic body and tail aplasia and also increased fat deposition within the pancreas. For HNF1 beta, it's more an aplasia, and for CEL, it's more for lipomatosis. So just reminding you that the carboxyl ester lipase mutation is in fact MODY8, and mutations in this gene can cause pronounced fibrosis, as you can see here on the histopathology, and acinar cells are actually not visible over here, nor are the beta cells. And over here, you can have a CT scan of this patient. As you know, it's autosomal dominant inheritance. Some members may have exocrine insufficiency without diabetes. And in both these, you can see a very prominent splenic vein. So there is obviously an increased distal runoff of blood over here. And what is prominent is actually the pancreatic lipomatosis and not calcification. MODY type 5, which is a multi-system form of MODY, Besides young onset diabetes can have renal cystic disease, uterine anomalies, uh, problems with the genitourinary tract in both males and females, and of course the pancreatic anomalies as well. And this over here, once again, I'm showing you the CT scans and the MRIs of patients with MODY for type 5 mutations. Now, what you can see in all these cuts is that there's virtually no pancreatic tissue in the region of the body and the tail. All right. And in addition to that, there is a very short pancreatic duct, as you can see over here. A very short pancreatic duct is present, but there's no ducts corresponding to the body or the tail of the pancreas. So this is extreme MODY5. Not all patients will have this, but this is something you should look for. And they can obviously have malabsorption, and this can be mistaken for fibrocalcic pancreatic diabetes, though calcification is not a major feature over here. And even in CEL, it's more lipomatosis with a smaller pancreas rather than calcification or duct dilatation. But both can have malabsorption and fat excretion problems. Here, comparing between the two types, the CL mutations and the HNF1 beta mutations, you can see the gross difference: lipomatosis in the CL, duct dilatation, and calcification. The absence of the pancreatic head in the patients who have underlying HNF1 beta mutations. So you can see the lipomatosis, which is very profound over here. And then we talk about the neonatal forms. Now, these other two which I mentioned, the CL and the HNF1 beta, occur in adolescence to adulthood to childhood, whereas these are largely neonatal presentations and very occasionally can present in adolescence as well. So the FOXP3 can cause mild pancreatic atrophy. The EIF2AK3, which is autosomal recessive, can cause severe pancreatic hypoplasia. We've already talked about HNF1 beta. And then you can have the PTF1A, which can cause pancreatic agenesis. The pancreatic homoject box mutation, wherein you can also have, is also a MODY, basically a MODY4. Pancreatic agenesis, no body or tail in the homozygous patient. The heterozygotes, they actually have pancreatic mass and can be managed with oral antidiabetic agents. And hypoplastic granular pancreas in the RFX6, autosomal recessive, and the GLIS3 mutation comes later in life and has small pancreatic cysts, but can mimic type 2 diabetes. So coming back to the table which I showed you about pancreatic size, in general, there are big differences between each mutation, but monogenic diabetes mentis unchanged or agenesis in these, depending on the type. Fat content may be increased, but in advanced chronic pancreatitis, on the other hand, there's no increase in fat content, and the size of the pancreas is, of course, reduced. Calcification may or may not be present in on the monogenic forms, and ultrasound activity is attenuated without calcification in patients with monogenic forms. So let's have an algorithm. If in case, now we need to have a sensitivity of picking up these cases when they are there, and thinking of other genetic conditions, which we haven't possibly been doing for a very long time, we should include this algorithm: pancreatic apoplasia, hypoplasia, and annular pancreas. Think of these mutations and do an NGS, next generation sequencing, to pick up these mutations. And the management and the prognosis changes. With a normal pancreas, think of the standard MODYs. Pancreatic hypoplasia and lipomatosis, think of HNF1 beta and CEL. And also one more I'd like to throw in is the mitochondrial mutations, which can cause recurrent attacks of acute pancreatitis and calcification, eventually with malabsorption. So let's end with a bit on some of the advances in hormonal physiology. And this work was done at our center in CMC. And a lot of it was supervised by my colleague, Dr. Riddhidas Gupta. And in addition to that, we had collaborations with the Albert Einstein University in the United States of America. So we had several questions in terms of what was the pathogenesis due to. Was there an insulin resistance component? They do not develop ketosis, so was there something else to it? What about the glucagon secretion? Was there any other issue? And so basically, we looked at a combination. We compared type 1, type 2, FCPD, and other forms. We looked at only male subjects. and we did hyperinsulinic euglycemic clamp studies. We did this very extensive pancreatic clamp to study these individuals. We, as you can see over here, I'm not going into the details, but we measured levels of glucagon. We also injected somatostatin growth hormone and glucagon at the start, which is called a total pancreatic clamp. We also looked at indirect calorimetry and NMR spectroscopy. And over here, these are the findings. We found that the lean mass is obviously much lower than that of type 2 diabetes. The hepatic fat content and muscle fat content were very similar to type 1 diabetes, and of course much lower than the other forms. When we looked at insulin and glucagon, and these are the key findings, the insulin levels were low, but not as low as type 1 diabetes. You see the two parallel lines at the bottom. The glucagon levels in pancreatic diabetes were elevated compared to that of type 1 diabetes, and in fact were higher than the phase of tropical pancreatitis. The insulin sensitivity, there was hepatic resistance present in fibrocalcic pancreatic diabetes and mild peripheral resistance in addition. So in summary, patients with fibrocalcic pancreatic diabetes on a longer duration of diabetes do have insulin resistance, increased glucagon secretion, and this seems to correlate with the peripheral resistance. So why is the glucagon high in spite of a fibrotic pancreas? So there are studies to show that in human beings, when the pancreas is taken off, the glucagon levels rise. And this is probably due to an upregulation of the pre-pro-glucagon genome, which is there in the L cells, which also produce GLP-1. And we hypothesize that it's probably coming from an ectopic source. So we next checked the other hormones, the hormones from the L cells in the intestine. And we did find, interestingly, that the GLP-1 levels were elevated in these patients, and the oxyntomodulin levels were also elevated along with the glucagon levels. So it indicates that there's probably an L cell overactivity in these patients. So in summary, basically this is the whole picture. High glucagon, high GLP-1, oxyntomodulin, suppress C-peptides and suppress pancreatic polypeptide. And therefore, we believe that the origin is from the L cells. We also found that the energy expenditure was extra high, which is an indicator that the carbohydrate intake should be very high in these patients, because beyond that of trying to build up their bodies and also compensate for their malabsorption that they have. You may have to give very high dietary requirements of 2,500 to 3,000 calories per day. Therapy-wise, very briefly, the insulin doses are around 0.3 units per kg per day. They are more prone for hypoglycemia, and we have done work to show that autonomic dysfunction is present in about 65%. Pancreatic enzyme supplementation is mandatory and should not be forgotten, and therefore increase the insulin dosing thereafter. And of course, finally, propensity for pancreatic carcinoma. I'd like to thank my entire department and many people who have worked on various aspects of this, and all our funding agencies in addition, and our collaborators. Thank you so much.